Awesome. Thank you very much for the very, very exciting introduction and all the flashing and all the videos. I think people are still having coffee. They will be gradually coming back in. Just, if you can raise your hands, who is here an AVF enthusiast, passionate and doing AVFs all the time, 50 times a day? Just 3, 4? Who has done an AVF once in his life? Once in his life? Not even once? No, I mean at least once. Okay. Who thinks that AVF is sexiest than fenestrated EVAR? Okay. Who thinks that knowing to do how an AVF but the end of this session will improve your skills for fenestrated EVAR? I assure you it will be. Well, what I can say for sure is that at this moment, most likely the field in vascular surgery that we have most of the innovations and very, very good trials is AVF, and we are very lucky to have some people that are going to educate us. We're going to start with my mate from Birmingham. Nick, would you come up and tell us about AVF creation, how you do it?
Thank you very much, and it's a real pleasure to be on a Paris catwalk. I never thought I'd make it this far. So I'm going to talk, I've been given the talk title when it comes up of Distal First or Do Your Best. And sorry, there's not a screen here, so if I turn around, it's just to talk through things. But in answering this, I'm going to present a case, because I think cases really do illustrate things, and these cases are translatable. So this is a case of Marie, 58-year-old from Glasgow in Scotland. I'll tell you why I've picked Glasgow in Scotland in a minute. She's been known for the nephrologist for some time now, for about a year. She's pre-dialysis, but her GFR's dropped from 21 to 15. She's starting to get to the point where she's thinking about dialysis. She's from Glasgow, so she smokes 20 cigarettes a day for 40 years. She's got a BMI of 37. So we can apply this question, distal first or do your best. And already I can see people starting to think, what would I do here? Well, I need more information. So this is Marie, sat on the stage, can't really show, but Marie's nearest to us there, sat watching TV. That's most of her lifestyle. She likes to eat fish and chips, deep fried food and smoke. She's not really interested in all this dialysis business, but we do a mapping, and the mapping shows this, that she's got a usable vessels at the wrist. She's got a perforator, so she would be suitable for a GRAC, she would be suitable for an ellipsis or a wavelength, but it's likely that that's going to go basilic dominant. She's still pre-dialysis, remember. At the elbow, there's a 3mm cephalic vein, 4mm radial artery, and a decent-sized basilic vein. So, again, should we go distal first here on this BMI 37, otherwise fairly unhealthy patient, or should we just do what we think is best? So let's look at the literature. These are the two options, obviously. How do we decide what is best? We can go to guidelines. This is in the UK, so these are the UK guidelines from 2015. And it says we recommend that an AVF should be placed distally as possible in a non-dominant arm. So we've got that option, but it's only 2mm and 2mm really. This is quite old. These are the new ones, which are even less clear as to what we should do. What we should do is we should treat the patient decision, and we should ask Marie what she wants. Marie says, I don't want anything. And this is why I chose Glasgow, because this is probably the best mapped data for any of this. And this is a fantastic study if you've not read it. And they looked at all patients for the first year after a decision to go towards hemodialysis access. It's by Pete Thompson and David Kingsmore's group. And those maps on the right, on the left here, you can see the blue patches are at the top bacteremias, at the bottom are hospital episodes. And the green are fistulas, and the pink are lines. And you'll see about 50% of these patients actually who started on a fistula didn't have a fistula at the end of 1 year. And about 50% started on a line. So actually when we're saying we should do distal first, this is all fistulas, not just distal fistulas. That actually only about 50% of these patients ended up using a fistula. And that's the same around the world. So what's the best we can do with the best evidence to make the best decision here is we can do a fistula, but the outcomes of fistula that has throughout 44% of patients who start at this point will end up with a fistula throughout that first year. 13% will switch to an AVG, and a number will end up having a central venous catheter out, about 30%. So actually, she goes through a lot. And if you start this patient on a central venous catheter, we know that's not going to be a good option. But if we start her on a fistula that doesn't work, is that going to be a good option? So what do? We counsel her and ask her what she wants. She keeps saying she doesn't know. So we convince her, because we know best, and we convince her. And the nephrologists say, you've got to have a left radiocephalic fistula. That's the best thing. It's distal first. It's what the guidelines have told us. We do it under a regional block because it's Glasgow. What do you think happens next? GFR drops further. Fistula at 4 weeks is 4.5 millimeters and 400 mils flow. She has a vein that's deep in the forearm. The nurse said, I don't think we're going to be able to cannulate this very easily. And the nephrologists say, we need to start her on dialysis and start her on a line. Now, that's a fairly typical story, and anyone who does access in the room, I'm sure, will think that they're not all thin, perfect patients with great veins that always work well. So distal first might not be the best option, and I put this here because I think it's different in different countries. I see Thierry here. Thierry would definitely do a distal first fistula on this lady, and he'd have 100% success. In the US, this patient with a 4 millimeter vessel and 400 mils flow is not going to do well on dialysis. And in Japan, this is going to be a perfect fistula. This is probably one of the better fistulas. So actually, doing your best depends on where you are in the world. So really, just to summarize here, because I can see Alex is getting warmed up, distal first is best, but that is only if the fistula works. And like all fistulas are better than everything else when they work. If they don't work, they're not better than everything else. What is doing our best? The guidelines really don't tell us anymore. They just tell us do what's right for the patient, and we don't know what's right for the patient, so it's a bit vague. But we do have other options. We have things like VASQ, we have the endovascular options, probably have more maturation options as we go along. So I'd like to thank everyone there and open it up, because this is more about discussion than just talking about a case.
Thanks, Nick.
This feels like the worst surgical exam ever.
Absolutely. So, Nick, that's a great presentation. And Thierry, of course, will always create a fistula for everybody because he's so awesome and he does a perfect job. But I think perhaps for such an obese patient, a graft might not be too bad. Perhaps this is why they do more grafts in the US, Sharendra, because you can do a tiny incision for the artery, you can do endovascularly the outflow, and the graft is going to be usable even day one if you use an early cannulation graft. So I don't know, Thierry, how you do it, and you do fistulas for everybody. She would need a superficialization, perhaps then a stenosis at the swing point and a dilatation, and she will get an infection with the superficialization. You don't get all these problems?
Obviously, if you have such a patient, you know that you are going to make a superficialization, but you know that from the beginning. And the vein is 2 millimeter, is probably more as soon as you have made the block, the axillary block, but after the end, this patient who have a fistula at the forearm, I don't think it's a good idea to have a graft at the arm.
So interestingly, in Glasgow, that's the study that David Kingsmore was about to start off with, is in marginal vessels, go for a graft as a first line.
Nick, thank you. I mean, that's a great presentation, and I do agree with you, like from the data you showed on Glasgow, what is to be done is based on your local expertise. If you ask me personally, I'm from US, and if you ask me what I would do on this patient, I'd counsel her right up front saying that you will need a 2-stage procedure. I'll do a radiocephalic. I will electively superficialize it in 3 to 4 weeks. If it's 4 millimeter, I'm going to put a balloon and make it 6 millimeter before I superficialize. I will not fault anybody in the US for putting a graft in this patient because that is the standard of practice. And what I'm trying to say here is that people should do what they are comfortable with their own results. I urge every one of us who do this to look at our own results and see what works best in our hands. So that's the key here. And having a catheter for probably 4 to 6 weeks, I would not consider it as a death sentence because we know catheter infection rate is probably 0.5 or 1 in all the trials for 365 days. So I think catheter will not be number one in my thinking. My thinking, what works the best for the patient in the given circumstance.
I think it's a good point. And the problem with a patient like this starting on a catheter, I think, is that they won't come off a catheter because they're disengaged to start with. And when you say, we're going to create something, then you'll need needles in, as soon as they've realized that it's not needles in the catheter, they're not going to be worried about central venous stenosis. They're not going to be worried about infection, I don't think.
Nick, I'm sorry. You had your time, your presentation. Now we'll let other people speak.
Sit down.
It's not because you have such a great accent, yeah? Okay, so Raphael and Panos is here. How are things happening in France and Greece?
In France, I don't know. You know better than me. Nick, thank you very much. It was great. To me, the first question is, what is the goal? Do we want this patient to avoid as much as possible a catheter or not? Is a 2 months dialysis catheter a big deal? I don't know. That's the first question. And then after, we have to consider two things. Anatomy, what can we do? But also comorbidities, because we know that we have factors here in this patient that are associated with starting the dialysis on a catheter. We know that women, we know that obese patient, we know diabetics patient, we know the patient with small vessels, they are really at risk to start the dialysis on a catheter. So anyway, when I see this case, I'm pretty sure the patient will start on a catheter, except if we manage to do a short a graft that can be fast puncture. My opinion would be that we know that we start on the catheter, and I would do the same as you did. Radiocephalic fistula to preserve the future, and accept 2 or 3 months on a catheter, the time to do the superficialization.
Perfect. Yeah. Can you announce yourself?
Yeah, hi, James Tunnicliffe, Cape Town. We also have anorexic patients like yours who lead a healthy lifestyle like yours. And we routinely will map our patients prior to surgery. Our problem is that we've got useless dialysis units, and they will happily clobber any access that we do. So I think our use of catheters is much higher than it should be. But just with your patient who you mapped, you had a really nice basilic vein. Yeah. And a basilic vein transposition in that sort of patient offers you all the advantages of a graft with all of the advantages of a vein-first fistula with just the maturation period to go for. So I must say, with your patient, in my environment, that's what I would have done. I'm just interested to hear what you think.
No, I think it's really interesting. And, you know, you can do a radiocephalic here, and it might not mature up in the forearm, but that might be, if it's dominant and it's 5 mils, you've probably got an option you can just swing across and cannulate pretty early. I think it's a great option. Alex, what would you do?
I would call you. So I think we go on because we started late and we're running out of time. So I'm guessing the majority of you guys, you're physicians. Who here knows how to get a potassium in a patient without drawing any blood, bloodless? Do you know how to do it? Can you do it? Is it doable? Is it doable? Who knows if it's doable? Raise your hands. Who says it's possible? Yes? Surendra? Who says no, it's not possible to know potassium without drawing any blood? Who says no? No? Okay, you're wrong. Because there's an FDA-approved device, and we're going to get all the relevant details by a guy who was a physician and a surgeon training to be, but then he was smarter, and then he decided to be an innovator. And thanks to all the innovation we're getting in the AV access world, now we have a wearable that can do all this nice stuff without drawing a single drop of blood. Isn't that exciting? Dave.
Thank you, Dr. Malia. Certainly excited to be here and talk a little bit about what has been done in the arena. I am conflicted in terms of being a shareholder in the company that's doing the research behind this, and maybe as well. So obviously we know, we've just heard a little bit about the fact that this is a pretty expensive problem, right? Just across the globe, even if you look at the US or here in the EU as well. But the question is should we be able to push ourselves a little bit forward in terms of kind of taking the traditional paradigm of maybe doing monitoring via an imaging study, or maybe looking after things like fluid status and hyperkalemia with a blood draw, and be able to take the world into a little bit of a different modality where being able to get those notifications means we can start to reduce the cost of care in this patient population, but most importantly, do the best for our patients. So I think the question is there a way to be able to, as was just said, being able to get all of that data completely non-invasively, passively without the patient needing to do anything, taking that data completely up to the cloud, running a series of proprietary algorithms on it, and then being able to give you as a clinician the right data at the right time so you can do the right intervention for the patient population. And that's what's out there now today. There are multiple FDA clearances. We aren't Theranos. I think that is important to state as well. But certainly from the standpoint of being able to get that data very effectively, being able to give you a notification, we don't want you to have to do more work, right? No one wants to have to wake up in the morning, start scrolling through more data, and trying to figure out and interpret it. Instead, being able to give them that notification that something is going wrong, and it is time for you to utilize your techniques and skills as a clinician to move forward from there is certainly important as well. Now, fundamentally, how is this technology different than what's been utilized? There are a series of optical sensors, but I think what's interesting is being able to get that data very, very differently than what you've seen with the traditional pulse ox or maybe even a smartwatch on your wrist, is if you could get the data from the actual vessel, so to actually target the photons that interact with that vessel, you get a much richer data set. You're able to get things like the actual vessel diameter, the actual vessel depth, how is that changing over time, how is the flow changing over time. Certainly making it convenient for the patient's important and for you as a clinical team in terms of making sure that you don't have to calibrate it. No one wants to have to do an ultrasound the day you put the patch on the patient. That's certainly important. Not having to do that, making sure the patient can live their life, it's shower-proof, it's sweat-proof, being able to also auto-calibrate for every skin color, so you're always getting the same accurate level of reading no matter what the patient looks like. Starting off with that is getting that data, much richer data set, much higher signal-to-noise, denoising that data further, taking an ability to actually look at each beat by beat throughout the day, making sure that you actually have really strong data set, and then being able to take that machine learning to say, what is actually happening? How does this compare to your blood draw or to your imaging study is important. If you look at just some of the initial metrics around potassium, hemoglobin, et cetera, as I mentioned, there were a series of actually a couple thousand blood draws that were done across a couple hundred patients, and comparing that blood draw to both the pre and post dialysis session to say across that entire range of data, is this accurate? Is this something that we can trust? And sure enough, there was an ability to show that the results were comparable to a blood draw, better than any other non-invasive modality like a Massimo system, and even better than a HemoQ, which does require a drop of blood. And so what that's led to is the ability to not only get your basic vitals, like you might imagine, but then also pushing past that into hemoglobin hematocrit, potassium, and then most recently, just a couple weeks ago, and funnily enough, where we started in the vascular access world, being able to notify you as a clinician that the patient is no longer having flow through that access is the first step on the journey for the access side. Those trend lines are certainly important. You can see what happens for a patient being able to, even when they come in to see you, being able to know what's happening is key. But if we take that access part a little bit further into, okay, great, flow, no flow is interesting, but where is this going? What is this going to look like? How is this going to impact me as a clinician? Is being able to get data around what's actually happening, being able to classify that. So here, taking that acoustic signal, being able to then utilize a machine learning algorithm and understand whether or not what does this lesion actually look like is certainly important to be able to give you a little bit of a better understanding before you even walk into the hospital or to see that patient, where is that lesion? And we can see that here. So here's a significant outflow stenosis on an upper arm access, very harsh frequency, harsh acoustic, as you might imagine as well. Actually looks very, very different than if you have a inflow lesion where you're not seeing that flow. Maybe you're seeing something very differently as well. So the research aspect is continuing to push that forward, being able to already look at things like your BP and your SpO2 and looking at it from a CKD standpoint as well of getting that same set of data on patients without an access. But just to highlight why does this matter and why is this interesting are a few arenas. For example, this patient, anemic, originally then also had their EPO dose titrated up, started to feel a little funny a few days after, but able to detect the fact that they were over the threshold. Wife took the afternoon off work, took him to the hospital. This actually happened up in Nick's neck of the woods up in the UK, and actually took him over there and had to have a blood draw done. But being able to avoid all of that and just say, maybe we need to titrate you back down could certainly change the current clinical paradigm of waiting, because otherwise this patient was not scheduled for a blood draw for another 3 weeks. Similarly, from an access point of view, what does that mean? This is from an observational study looking at maturing fistula, so placing the patch right on the patient as soon as the access is created, waiting to see if they mature, don't mature. It's a nice, fun question. We're all trying to figure out, is it going to happen, is it going to not? Where is this patient going to know? Being able to then get that, as compared to, in this study, getting a duplex every 2 weeks, being able to actually be predictive and say, things aren't going right. This is not a maturing fistula, something is going wrong, and getting that decision before, I think this was brought up, should we balloon, what should we do, what is the intervention? Likewise for hyperkalemia as well is certainly important. I think in conclusion, where is this going to go? It is going to change perhaps that clinical paradigm, certainly needs being able to get a group of clinicians that are excited about where the future is going, but I think also how can we best utilize that data to take care of patients the best. So thanks.
Awesome. Thank you, Dave. Dr. Veselius, would this be useful in Finland?
Well, I think that it's an option. It would be an option because we're a big or a long country with very kind of few patients, under 2,000 patients in our country. So the distances to hospitalization, for instance, are long. And also the people are very individually living around the country. I think that this could be an option.
So how many blood draws can you save an individual patient per month or per week, if you wish?
So I think it depends on what country you're in. I think if you're in Austria, I think they do actually do one before and after every session. So potentially you're saving all of those. We've seen that in a couple of trusts in the NHS as well, where they've actually tried to send nurses to patient homes to do a blood draw on the off dialysis days. Saw that they reduced their A&E visits. But I think it's really taking that modality. People are trying to solve the problem somehow. But now the fact that you can wear something, the battery's going to last 2 to 3 months. So now the patients can wear it chronically, go live their life, and otherwise you're getting that data throughout the day. And as a clinician, you can either get those alerts 24/7 if you have a team that's looking at this or whatever it might be, or you can just get them at 7 a.m. when I'm on my way into the clinic. I want to be able to know who I need to best tackle and where to spend my time. You can get it that way as well.
Absolutely. And if you wish, I think what's the most important, which is not always so easily measurable, is the patient's comfort. And how many times have we seen patients suffering because they don't have veins and we have to stick them, and they're yelling and screaming and crying, and we have to stick them over and over again to draw potassium. So if this suffering can be improved, I think I'm all in. Louis, I have an interventional nephrologist that I'm training in Paris. He's from Belgium. What do you think as a future interventional nephrologist about this device?
I think that is really interesting for potassium, because as a nephrologist, the real difficulty is during the weekend, when people can eat more bananas or something like this, and that can make a difference for those patients when they have a cheat meal, and maybe we can call them to ask them to the dialysis center and make an extra session to save their life. So I think it's really interesting.
Awesome. Dave, thank you very much. Is there any other question or remark? Surendra.
Thanks.
And then...
Just one question.
Yes, please.
Very, very interesting, the future. Is the patient at an alert or only the nephrologist when there is a problem?
So there isn't a patient-facing app today, mostly because we don't want the patients calling you all the time. That will happen. I think it'll be more focused on education in terms of kind of that question of, the long duration, between dialysis. As a reminder, please make sure you watch your potassium intake. I think that's where that will head on the patient side. Right now, it is completely clinician-focused in terms of getting that alerts, just to keep once again, keep the blood pressure down, I think, on the clinical side.
Thanks.
Nice presentation. Dave, I have a quick question for you. In the ideal world, how often these patches have to be changed? Like if I were to use it all the time, and what do you see in your future, the capabilities of the patch in terms of monitoring other than potassium and hemoglobin and heart rate? what else? What are the things you think you can monitor with this patch with non-invasively?
So from the patch perspective, the battery lasts about 2 to 3 months, able to actually, kind of like the CGM devices where you have a little bit of overtape. Change the overtape about every 10 to 14 days. You can actually wear that until the battery dies, so about 2 months worth of wear per patch. I think on the access side, taking it from, once again, it's really a regulatory journey. We've done, I think you've seen some of it in the past, right? We've done the data on comparing it to an ultrasound, comparing it to a DSA. That's really more of a regulatory question of how do you stepwise this as compared to an ultrasound. Big question being, what we've seen is a lot of variability in your ultrasonography cohort in terms of their accuracy. But since you're actually getting a full kind of volumetric and circumference rather than just a diameter, you're able to actually get flow. And then comparable, once again, to telling you where that lesion is. It is a proximal lesion in this arena. It's about this much stenosis. That's the access side. And then on the general capability side, the idea, I think, of the 5-year horizon is effectively all of your vitals, hemodynamics, and effectively a basic metabolic panel, completely non-invasively. Once again, there's no needles, doesn't require any blood, et cetera, no calibration to start off with.
Dave, I can only congratulate you for what you're doing for patients. I think the dedication and hard work that you do for this level of innovation is difficult to understand for the most of us. Just when you get your Nobel Prize, don't forget about me, okay?
No, you've all been great supporters, so thank you.
Absolutely. And, you know, I'm feeling sorry for the guys that didn't come in in this room, but because it's very rare that you have the opportunity to have these two ass-kicking speakers presenting. They are like living, moving encyclopedias of data. Bart and Scott, they're going to talk to us about DCBs and covered stents in AV access, and they know like the whole literature, the data, anything. You can ask them anything you want. Who's starting?
All right. Bonjour, chers collègues. I'm taking the position of DCBs. I'm going to start with this slide, which I think is the most important thing I can say. For those who don't speak English, I'll tell you that I know I'm going to lose this debate. Everybody loves stent grafts. They're like candy. But if I can, in giving this talk, convince even a few of you to use fewer stent grafts, then I will have won the debate nonetheless. On y va. So let's refine the debate a little bit. This is not a complete area of overlap. There are areas where a stent graft is obviously the right choice. There are areas where a DCB is the right choice. What we're going to debate here is the nexus of those two here underneath the pyramid. So first of all, where do stent grafts win? Well, first of all, we have loads of level 1 data, which all coincide, have the same result in vein graft anastomoses for stent grafts. So obviously, that's an area where stent grafts win. If we have an elastic stenosis, when we inflate the balloon completely, the waist disappears, but we get elastic recoil that does not respond to prolonged inflation, then yes, of course, we're going to put a stent graft there. Likewise, if we get a rupture that does not respond to balloon tamponade, but it does 90% of the time, but if it doesn't, of course, we're going to put a stent graft there. So that's not what we're talking about. And I would argue that there are some areas where DCBs win, what I call the no stent zones, the cannulation zone, although that may change over time, and also the anastomosis, of course, and even some very close perianastomotic stenoses can be very difficult to put a stent graft in. And there are certainly areas that I believe, at least, that neither of them win. I think that everybody should get a POBA at least once the first time around because there is this virgin effect. And there are, for immature fistulae, at least right now, you can get often a single POBA will get that fistula to mature, and it may last years. So let's assume that we've gotten a great result after angioplasty. We fully effaced the waist on the balloon. We got less than 30% residual stenosis. We don't have any rupture. And in that setting, which, by the way, can be achieved 90 to 100% of the time just with a balloon, because it's been shown in all these big randomized trials of DCBs, where that was a criterion of entry for the study. And in those patients, like if you look at the consort diagrams for those studies, 90 or 100% of patients, this could be achieved. We have a proportionality problem here. We have loads and loads and loads of multi-center trials. We actually have 5 multi-center trials of over 1,200 patients in DCBs. Problematic a bit because they don't all agree in their result, but we have a lot of data. Whereas for stent grafts, we have a single multi-center trial with 280 patients. So does David slay Goliath, We're going to find out when Bart comes up. And this is what we think we know from that study. This is the Avenue study, which Bart is the PI. And in that study, which is we now have 2-year data on, we found that an imperfect result from angioplasty can be ameliorated. You can get better with a stent graft. If you get a bad result from angioplasty, you can put a stent graft in and get a good result. Now, I'm going to justify that statement in just a second. So here are the data. Obviously, much, much better with the stent graft than with angioplasty. But I draw your attention to these results down here, even at 1 year, okay? So what do we know about stent grafts from that study? Remember, that study's in AVF. We're not talking about grafts here. So we have to have, this is what we don't know. We need a randomized trial done like the DCB trials, where we got a very good result with POBA, with plain old balloon angioplasty, and then put a stent graft in. That's not how this trial was conducted. And we really need long-term data to see what happens after that 2-year point. Because if you get really bad restenosis in a stent device, we know what happens. We know that from the rescue trial. In the rescue trial, which was bare metal stents, which get this horrible restenosis like you see here, we saw that even when you did put a stent graft in, yes, it was statistically better than angioplasty, but come on, folks, these results are absolutely terrible, even at a year. We're looking 20% patency. So once you get that restenosis, you have a big problem if there's a permanent device in there. For DCBs, we have a bunch of systematic reviews that all say the same thing. They say we should be using DCBs. We couldn't possibly have systematic reviews for stent grafts in AVF because there's only one study. What do I mean by good angioplasty? This is important, okay? Here's a patient with a left upper arm basilic vein transposition fistula. They have a stenosis here at the swing point, which is greater than 50%. Starting with an 8-millimeter balloon, which is undersized, unfortunately. We didn't get a good result, so we used the concept of progressive oversizing to go to a 10-millimeter balloon. With a 10-millimeter balloon, we had a lot of elastic recoil, so we used prolonged inflation, 5-minute cycles of 2 times 5-minute cycles if we need to. After that, we were able to achieve less than 25% residual stenosis. This is a good angioplasty. And this is what was done in those DCB studies, and this was not done in the Avenue study. So let's look at the results of good angioplasty in those randomized trials. Here is from the Chinese study. You can see that these are all multi-center trials, by the way, okay? We can see here that if you look at the DCB group, which was statistically better according to their combined endpoint than the angioplasty group, but even in the angioplasty group, we're able to achieve 80% patency at 6 months. Those are the Kadoki recommendations, by the way. This is from the PAVE study, which was a negative study for DCBs. But again, if we look at the results here at 180 days, you can see that we've got 75% or so in the control group, okay? If we look at the impact study, which is, of course, the study that got the best results, okay, so it's kind of the best one out there in terms of results, we can see that if we look at 6 months, we have a 70% primary patency in the control group. And if you look at the DCB, it's 86%. Remember that number. And then this is from the Lutonic study, a negative study, but nonetheless, you can see that at 6 months, we're able to achieve about 65% in the control group, and in the treatment group, about 70%. Now, this is from the Avenue study. This is the stent graft versus angioplasty and fistulas. You can see here that at 6 months, we have only 50% stenosis in the angioplasty group. So what happened? Remember, all those other ones had 70, 80% primary patency in the angioplasty group, in the control group. This one does not. It's only got 47%. And if you look at 2 years, or at 1 year, it's down to 20%. And we've got 80% success in 78% success in the stent graft, which is the same as the treatment arm in most of the DCB studies. Bart will tell you that this is the real world. This is how it's done, okay? Nobody does a good angioplasty like I just described. I would argue that's not true, but let's go ahead and assume that it is, okay? So these are the 2 best result studies we have. The one on the left is the impact study of DCB. The one on the right is the Avenue study, the only study of stent grafts and AV fistulas. And if we look at the results, and here, remember, these are 3-year results, and these are 2-year results, okay? And if you look at the difference here, obviously very good results in both studies, but look at the difference in the survival curves. So if you're Marie and you get to choose What are you going to choose? Are you going to choose a 50% 2-year primary patency and a 43% 3-year primary patency at the same or lower cost as the stent graft with no metal left behind and no issues of breakage, migration, skin erosion, and no bridges burned? Or are you going to choose a stent graft which has only 40% 2-year primary patency, the same as the 3-year in the impact study, and a metal footprint with all of those associated issues? Merci de votre attention.
Absolutely awesome. I'm already convinced. I'm not sure, Bart, we need to come on the stage. Bart, I'm sorry, buddy. But let's hear you.
Have at.
All right, thank you. Well, thanks, Scott. As Alex said, we're ass-kicking, and I'm going to kick your ass. Well, great. It's great to be here and great to see so many people. Thierry Porcher, I haven't seen you in a while, and many others. I'm going to talk about covered stents for AV fistula stenosis, which I thought was what the topic was. My disclosures, and I do I've worked for over 25 years developing covered stents for AV access. So I guess that's my disclosure. Well, if you look at what a stenosis is, it's really just a luminal narrowing. And you have to drill down a little further to understand whether you're going to use a plain old balloon, a covered stent, or a drug-coated balloon by understanding what it is that we're treating. So I'll show you an AV fistula stenosis. And the question is this caused by neointimal tissue? Or could it be due to negative remodeling? And I think this is one of the important factors that we've overlooked when we try to take one tool and apply it to all areas of AV fistula or AV access narrowing. And the question is this really important? And the answer, I think, is yes, it's very important. This is a patient with a juxta-anastomotic stenosis, and you can see this is entirely negative remodeling. This is just a vessel that has caused constriction, and there is no neointima that's related. Here's another case with just a little bit of subtle, let's see if this is points, a little bit of subtle neointima perhaps. Almost all of this is negative remodeling and contraction of the vessel itself. I can't seem to go back on this. Oh, there we go. Well, there's an interesting study done by Yamamoto, 46 patients who had AV graft venous outflow stenoses. They were all balloon dilated, and the patients who came back with a recurrent stenosis were then characterized using ultrasound. Yamamoto looked into the ultrasounds and characterized these stenoses in 3 different ways. There were those that had vascular constriction, shown on the top, those with neointimal proliferation in the middle, and those that had mixed lesions that were both constricted and had neointimal tissue. And what he found after treating all of these recurrent stenoses with balloon dilation and bare metal stent placement, is that if there was no neointima at all in the lesion when he treated them, they had a much better patency than the lesions that had any neointima at all. So I think this is one of the features that we're missing when we're talking about plain angioplasty, drug-coated balloons, or covered stents. Do we have any histologic correlate to the ultrasound findings? And we do. Kate Steiner has published this. Ultrasound appearances and histological correlation of native AV fistula stenoses. And in her work, she states, AV fistula stenoses are not a uniform group as demonstrated by different sonographic and corresponding appearances at histology. So we really do have different causes for AV access or AV fistula stenosis. Well, is there any role for a biochemical inhibition pathway that is a drug-coated balloon if we're treating a lesion that has no neointima at the time of treatment and that may not develop any neointima? And I would say there's no real reason to use a drug-coated balloon because all it's going to do is act like a plain old balloon angioplasty. How about a covered stent? Well, this can treat all types of stenoses, whether they're negative or constricted remodeling, neointimal hyperplasia, extrinsic compression, hyperplastic valves, organized mural thrombus. They're all excluded by placement of a covered stent, which is what I call them. Now, admittedly, covered stents are not the final answer to everything. You can get edge stenosis, which is the biggest liability of placing a covered stent. But this, of course, is one of the failure mechanisms which can occur. But overall, when you compare the covered stent to plain angioplasty in all of the studies that have been done, prospective studies that are typically randomized and some of them that are just prospective single arm, you'll see that the results are much better than angioplasty alone. As Scott Traratola showed you, there's a difference in these curves. The angioplasty group almost met the 50% patency at 6 months, which is the K-Doki criteria established several decades ago. So I can't say that it's really an inferior result. And whether or not a prolonged balloon angioplasty is better than the angioplasty, as most people do it, is still unanswered. We just don't know if a prolonged balloon dilation matters at all. Can we compare outcomes using drug-coated balloons and covered stents? Well, the reality is we really don't have any head-to-head comparisons. There's been no prospective randomized study where you use a drug-coated balloon or a covered stent. But can we get any data at all from the studies that have been published? And I'd say if we wanted to look at this, we have to be sure that the studies were well-designed, large, randomized, and used the same control group and had similar patient demographics. And then we can look at the same type of lesion. I mean, one of the flaws in Dr. Truratola's presentation is he's taking studies such as the IMPACT AV, where they're treating a lot of radiocephalic forearm fistulas, or other studies perhaps where the mix of lesions is different. So let's take a look at the same type of stenosis in all three of these studies. I'm going to talk about the IMPACT AV, the Lutonix, and the Avenue trials, which is drug-coated balloon, and covered stent. And you can see they have roughly the same number of patients enrolled. They all randomized to balloon angioplasty. The ages were almost identical as far as the mean age. Male to female ratios were about the same. Hypertension was endemic, diabetes in about 2/3, and restenotic lesions were treated in about 70 to 75% of patients. So we're going to take these three studies, and now we're going to look at this one problematic type of stenosis, the cephalic arch stenosis. Now, this is a difficult lesion. This can be caused by hyperplastic valves, extrinsic compression, neointimal hyperplasia, and negative remodeling. And this is what we see when we look at the data just for the cephalic arch stenosis in these three studies. In the IMPACT study, 66 patients were randomized between balloon angioplasty and drug-coated balloon. In the Lutonix study, 58 patients were randomized, and in the Avenue study, 148 patients with cephalic arch stenosis. Well, let's look at the 12-month data on patency at the target lesion site. And you can see with angioplasty alone, plain angioplasty did quite poorly at 12 months, with both IMPACT and Lutonix showing only a 29% target site patency, and the Avenue study showing 13%. The covered stent in the Avenue trial gave almost a 50% patency in the cephalic arch at 12 months. And if you look at the drug-coated balloon trials, IMPACT showed a very good result with almost 58% patency at 12 months, whereas Lutonix showed 28% patency at 12 months. And you can see the data for the drug-coated balloon trials is kind of positive and negative. We're just not sure still, despite the fact that we have so much data, whether the drug-coated balloon in the cephalic arch really matters or not. Whereas you can see a benefit in the Avenue trial, which had more patients enrolled than the other two drug-coated balloon trials together. Well, Scott mentioned that you're putting in this metal device and you got to live with that. And I'd say, well, how about that notion that you don't want to place a permanent implantable device in your patient? And I say, well, that's just like your opinion, man.
Head, shoulders, knees, and toes.
So head, shoulders, knees, and toes. And knees and toes. And if you look further, we put these implantable metal devices into elbows, hips, spine. They're used in the cardiovascular system widely as coronary stents, pacemakers and defibrillators, thoracic aortic stent grafts, abdominal aortic stent grafts, LVADs. So we're putting in devices in all sorts of places and all sorts of people because medical implanted devices save lives, improve lives, and serve as bridge to better lives. So I say, if you're reluctant to use a covered stent in a patient who has end-stage renal disease on dialysis with an annual mortality somewhere in the range of 10 to 15%, but the device gives them a much better quality of life, consider using that device. Well, let me conclude by saying Covered stents versus drug-coated balloons. First off, not all fistula stenoses are related to neointimal hyperplasia, and many of them are due to negative remodeling or other causes. Covered stents treat all forms of AV fistula stenosis. Comparable lesion types in very similar studies show conflicting results for drug-coated balloons, and yet market patency benefit with covered stents in a very large group of patients, 148 patients randomized. And finally, appropriately used implanted AV access covered stents, like other cardiovascular devices, save and improve lives. With that, I'd say covered stents make sense. Follow the data. Thank you very much.
Bart, amazing presentation as usual. Thank you, but not thank you, because I was decided and now I'm confused again. So I have to challenge you both with 2 questions, one for each one. So, Scott, you have these amazing results of POBA in these trials, like 60% patency rates, 65% patency rates at 6 months, if I read correctly, yeah? And in the trials.
Yep.
And the truth is that this looked pretty amazing, and you know, POBA, it's not really rocket science, it's a very simple thing to do. But I don't think most of us have these results in, you know, daily practice, and I don't understand what we're doing wrong and how we can fix this. I mean, is it because we're not enough, you know, patient to keep the balloon more, or we don't use the right size of the balloon? And how do you think we can fix this and do POBA more appropriately?
Well, again, the debate, as we point out, was DCBs versus stent grafts. So I was talking about that. I used the POBA example because I wanted to make sure everybody understood the differences between how the trials were conducted. So let's make sure we're clear on that. In terms of getting it right, I showed you the secret. There is no secret. It's just using the right size balloons and progressively increasing the size of the balloon, effacing the waste on the balloon, and prolonged inflation as necessary to get that kind of result. And the nice thing is that we've got loads of randomized data now that show that you can get a very good result with POBA. And we also know that in certain situations we can get better results with stent grafts or with DCBs or both. And I think hopefully what people take from this is that there is not a one device that's the right device to use, right? Bart and I are taking positions that we don't necessarily believe in because we know that there's times for a stent graft, and there's time for a DCB, and there's time for POBA. But I do think that if you're going to spend whatever it is, 100 euros or 200 euros on an angioplasty balloon, you should maximize the value that you get from spending that money.
Alex, if I could comment,
Yeah.
to Scott's point, I mean, we chatted a little bit just before the debate, say, what can people take away from this? How can we move forward? The study that's never been done is to compare what Scott's advocating, which is trying to do the absolute best balloon dilation, prolonged, going up to the right sizes, doing everything as well as you can, versus standard of care, if you will, or how most people do angioplasty now, which is often 2 short dilations, 1 balloon, and they're done. So I think that if that study were done, we could answer the question if an optimal or the best angioplasty approach really does give a better durability for patients with AV access stenosis.
Well, I think this is really turning out to be an ass-kicking debate, and I'm going to try to ask an ass-kicking question, and feel free to intervene. Is there a chance that the criterion we're using for covered stents, the target lesion primary patency, which is absolutely appropriate when we're judging other things like DCB or atherectomy, because what you want to know is what's happening with the lesion. But when you place a covered stent, the lesion doesn't exist anymore, and you have the stenosis at the edges of the stent. So is there any chance that we have these great results because we are cheating at the TLPP instead of judging the overall access circuit? And what do you think about that?
Yeah, so first off, in the covered stent trials, the target lesion, when you reevaluate it later on, includes some distance beyond the covered stent. So you will capture edge stenosis. So you're not cheating in that way. If there's edge stenosis, it will be included as part of the target lesion restenosis. Okay?
And I would just add that, the target lesion primary patency is an artificial measure designed because we have to make the Food and Drug Administration happy. And because in dialysis circuits, so many other things can happen. You can have other lesions. Obviously, access circuit primary patency is a much better measure. You know, realistically, did this patient have to come back as soon as they otherwise would have if we put a stent graft in them? You know, and that to me is the most important. That's what Marie wants, right? I mean, they don't care about target lesion primary patency. They care about access circuit primary patency.
And much of that is related to study design. For instance, in the Avenue trial with covered stents, we included slightly more than a third of the patients with second lesions in their circuit. They were not target lesions, and they could only be treated with balloon dilation. Well, that right there is going to degrade your circuit patency because of restenosis, which happens more often in an angioplasty site than on a covered stent site. So part of this is what the FDA wants and how you answer the primary endpoint, but also has to do with who you include in the study. For instance, the IMPACT AV trial only, as I recall, only had primary target lesions. They didn't have secondary lesions, and they could show better circuit patency because they only had one site they're treating. Whereas the Lutonix study, I think, included secondary lesions, and so did the Avenue covered stent trial. So study design is really important in how you
absolutely. It's a major thing. And when I was seeing all this hardware, you know, you were showing in the knees and shoulders and head and everywhere, I was thinking, oh my God, you know, the cemeteries. How much hardware are you going to have in the cemeteries all around the world? But we have to be honest, and you know, it's a secret between us. I think we are just a few here. There is also the risk of overdoing it. Is it, you know, the industry pressure? Is it because when you place one stent, you're not happy, you can easily place one more? So I do get there is a point of not leaving hardware behind, as Scott was mentioning, and is also the risk of converting a fistula to a graftula and all the infections you're getting. Is there any risk in your practice with infections or the stent eroding the skin?
No, I don't think that infections are the big problem here. I mean, I honestly think that if you prolong the patency by another 6 months, 12 months, 2 years, Scott and I were just talking about a patient that had a complete occlusion, had a covered stent, and went 4 years, no problem, no restenosis. I think you're doing a great thing for these patients. And I don't see that infection as a problem with covered stents. It's not really, it's been reported in covered stents in aneurysmal changes in grafts, but now people are also reporting excellent results in covered stents and cannulation sites themselves. So.
Any opinions from the audience in the covered stent? Who are you using covered stents or DCBs here in the audience? Has anyone has an experience on the topic? Yeah. Microphone. And if you can announce yourself.
Hi. Hello, I'm Andrea Pinel. I'm from Portugal. We actually use all of the hardware we can and what we think it's suitable for each case. And we are actually adding one more variable to the game. We are actually using drug-eluting stents for some lesions, especially for the cephalic arch, because we are kind of sometimes when the lesion is really close to the cephalic arch, because of the landing zones, we are afraid of the cover stent may jail the outflow and may preclude a future, for example, a basilic fistula. So we are actually having very good results with the drug-eluting stents.
So just to understand a bit better, let's get a scenario. I have a patient with a brachiobasilic fistula, and this, I guess, time-wise, it's going to be the last one. Brachiobasilic fistula, 1.4 liter of flow, stenosis of the basilic vein outflow at the swing point up at the arm, high pressures. I do a POBA, and I have 60% residual stenosis. And then I do a new POBA, more prolonged, and then it's 30% residual stenosis. And clinically, it feels a bit pulsatile, okay? And I do the DCB to improve the thing, or at least to have less risk of recurrence. And I still have a 30% residual stenosis, 1.5 liter of flow, fistula a bit pulsatile. At this scenario, do I put a covered stent or not? Do you need to repeat? Do I need to repeat this?
No,
scenario?
no. You're asking me.
Yes.
Okay.
Or somebody. Anyway.
Yeah, no. I mean, for sure, you could follow that patient. I think if you pulsatility is a bit of a measure that we do on a physical exam, but exactly how that's impacting the patient, maybe they're getting great clearance. You have only 30% residual stenosis, and you can follow them before doing anything else.
It was a surgeon's trap for an IR. What about flow reduction? You have a 1.5 liter flow fistula. I took you out of the subject of the debate. I'm sorry.
You could always reduce the flow. I mean, you have plenty of room to reduce it and reduce the pulsatility if in fact you feel like treating the pulsatility is mandated, you know.
But is it sometimes that the high flow and the high pressure is creating these lesions?
Absolutely, which is why I say reducing the flow, whether it's a proximal banding or some other measure to reduce flow, might be the only thing needed after you do the angioplasty.
Surendra? So 1.5 liter flow repeatedly ballooning, or reducing the flow at 600? Okay. So I do agree with Surendra, and I think we are creating high flow fistulas, and this is often the cause of the problem. And is this functioning? So I think the problem is that we're reducing high pressure, high flow fistula, and this is often the problem. And with that, I think we can move on to the next topic, which is